Our second speaker is Dr. Colin Doherty, who's a consultant neurologist at St. James's Hospital, and he's going to speak now about the Trinity College Concussion Research Interest Group.
Thanks very much, Chair. Good morning, everyone. So if you're not thoroughly freaked out by that talk, you're not awake. Yeah, every time I hear the data put together, I take something more worrying from it, especially when I have my own kids playing, contact sports. Hopefully we will get a robust discussion about that. Okay, so the good news is that, how do I move forward? Oh, it's the green. We don't necessarily interact when we have these talks, and so I'm going to cover a little bit of the ground that Peter covered, but I'll go through it faster and try to talk specifically about the research. So this is the original paper that Peter mentioned by Martland, who's the forensic pathologist in New Jersey. And I think it's worth it. The first paragraph is worth reading out. Now, I've realized that I can only read this out if I use my 1928 radio voice. Okay, ready? For some time, fight fans and promoters have recognized a peculiar condition occurring amongst prize fighters, which in ring parlance they speak of as punch drunk. Fighters on whom the early symptoms are well recognized are said by fans to be cuckoo, goofy, cutting paper dolls, or slug nutty. So, thank you. What he does in the paper, it's really interesting, and you can get this online. You can get it in a PDF format. It was well worth reading. He draws a line between what the common causes of dementia were in the 1920s, which are quite different. I mean, Alzheimer's disease was only diagnosed in 1914 by Alzheimer in Europe. Really, dementia was consisting of tertiary syphilis, persistent cephalitis, vascular disease. And he said that these conditions were very similar to what he was seeing in boxers. So this idea that boxing causes dementia at all times, in all eras, is widely known, and it's been known for nearly 100 years. So we're not talking about anything new. Anybody recognize this picture? Anybody? Alvin Blue Lewis. Right in, where's the field? Right out here, 1972. This was Ali's comeback fight, okay? And it was Michael Sugru who brought him back. Butty Sugru, who brought him over. £300,000 he gave him to come to Croke Park to fight. He was expecting 60,000 people. He had 15,000. But Alvin died of dementia about 20 years later. And we know, of course, what happened to Ali, and there's that paper again that Peter mentioned in 1969, and this study of what he called traumatic encephalopathy was well described. So, and that's the paper again that Anne McKee and her group have mentioned. I think just it's worth adding to what Peter said about that. So this is 111 of ex-NFL players of 112 examined. So that's 99% of them had CTE. Now what they said was, this is very interesting, this is addressed the bias question. Or are people putting their hand up and saying, I want my brain donated because I'm suffering from depression, or I want my husband's brain, or I want my dad's brain donated? So, in other words, all of the symptom people were putting their names in, would suggest a strong bias. But what they said very, very persuasively was, assuming we missed everyone, let's say nobody else had CTE. In other words, everyone else was completely fine and we missed it. Then, by estimating the number of deaths over the period of the study, they reckon that the lowest possible figure for CTE in NFL players was 9%. So that's very important. That's assuming they missed everyone else. So the lowest possible figure is 9%. Obviously, the highest possible figure is that everyone is somewhat affected. And so this is where the research comes in. Right, very briefly, on the left, some of you who are not used to looking at brain scans, we look at them every day. This is a CAT scan. This is a normal brain scan. You see the folds of the brain. These areas here are fluid-filled ventricles. They're normal. You don't need a PhD to understand this is a very abnormal scan. This is a typical traumatic brain injury, severe. The white stuff is blood. You can see the break in the skull. And you've got blood here, which is called subarachnoid blood, which is coursing through the other part of the brain. So traumatic brain injury is something we deal with all the time. In Europe alone, brain injuries cause 66,000 deaths, almost 1.6 million admitted to hospital each year. More people suffer traumatic brain injury than the numbers diagnosed with breast, lung, prostate, brain, and colon cancer. So I think at the beginning, someone mentioned this question in relation to, say, stopping smoking, in relation to plastic bags. If there was ever a public health question, traumatic brain injury raises it. This is definitely a public health issue. This is not a niche area. The interesting thing is that there's little change in the treatment of acute brain swelling, which I'm going to talk about, in the past 80 years. So when somebody comes in, they have a severe injury, and their brain swells up, how we treat that has really not changed very significantly. The estimation of 3.8 million mild traumatic injuries, mostly from recreation in North America. And you can see that's a fairly dramatic example. By the way, he finished the match. He wasn't taken off, and he finished the match, and he had no symptoms after it that we know of. So the issue of the definition of concussion has been controversial. I'm not going to dwell on that too much, except to say that in my business, we're well advised to stick with our professional organizations when it comes to defining things. So this is the American Academy of Neurology definition from 2013, a clinical syndrome of biomechanically induced alteration in brain function. So it assumes that brain function is altered, and it typically affects memory orientation, which may involve a loss of consciousness. So it's a clinical syndrome. In other words, you have to have symptoms. It's not just about the force of the injury. And this is very important. Obviously, people come to doctors and go to clinics because they're complaining of something. But nobody has come, I've never seen a patient who's come in, brought in by, say, a parent or a coach saying, this guy took a massive bang on the field yesterday. He's no symptoms at all, but I'm worried about him. That's never happened. But it's an interesting question. So, again, our normal brain scans, this is the problem. So in the area of concussion, we're talking about, by definition, a normal brain scan. Now, that's a little bit of a controversial point because there are lots of scans that you can do, and you can get more sophisticated with the scanning to look for abnormalities, and I'll address that. But in simple terms, the sort of standard clinical evaluation, a patient comes into an A&E or a clinic, this is the kind of scan they get. And by definition, it's normal. Once it's abnormal, then you're into mild and you're into moderate and severe. Okay. So what we're left with is trying to understand symptoms. And where I got interested in this was the case of Kenny Newsom, and Kenny's family have been happy for us to talk about his case in relation to the value it is to talk about his case in a public health terms. So that's why we can name Kenny. And this was a story by Brendan Fanning, who reported the paper that was published by my colleagues in relation to Kenny's death. So Kenny was admitted to our institution in James's. He was brought in by his family because he wasn't managing at home. He had a 5-year history of deterioration in his cognition. Now, he had a long playing career in amateur rugby, and we didn't know this. So it wasn't volunteered as an issue. And actually, we made a diagnosis of a kind of reasonably rare syndrome called progressive supranuclear palsy, which is, probably, you might diagnose that 5 or 6 times a year in a standard neurology clinic. You'll see it more in dementia clinics, but so we had no inclination that this guy had any other disease than this sporadic, rare form of dementia. However, when he died, and he died of a pneumonia, he became bedbound, he wasn't able to move, he got a pneumonia, which is a common cause of death in people with dementia. When his brain came to autopsy, the pathologist, Michael Farrell, recognised his name because Michael is involved in amateur rugby, and immediately thought, is this possible that this is what he had? And these are the pathology slides. So thankfully, Peter's done all my work for me. So this is this hyperphosphorylated tau deposition around the blood vessels. That's a blood vessel. This brown deposition is the tau. This is the classic feature of CTE, and that's the paper. And the first author on that is Willie Stewart, whom you'll know. He's a neuropathologist from Scotland. So Michael got on the phone to Willie immediately when he thought this might be the case. And it was Willie who came over. He flew over to examine the case, because this is the first case of CTE diagnosed in rugby player. And Siobhan Hutchinson is my colleague who looked after Kenny in the ward. So when I got interested in this in a more formal sense, we went back to look at his brain scans, and this is a PET scan, which Peter's also mentioned. This is the structural brain scan. And we started looking at some of these minor abnormalities. Now, these are not, again, there's no way of diagnosing CTE from ordinary brain scans. So we just took a guess at looking at some of these spots which were a little bit abnormal. you might see these. In fact, I do have a few of these. These are white spots. Once you're over 40, everybody has a few of these floating around in the brain. But we decided to look at these, and I worked with this guy called Matt Campbell, who's Matt is not here today, but he's a basic scientist in Trinity, who is, I'm going to give him the credit for this. He's the genius behind the work we've been doing. And what he does is he works on a thing called the blood-brain barrier. So I'm going to show you. This is a blood vessel here, and it's lined with this red protein called Claudin-5. And this protein basically are little gap junctions. I'm going to explain what they are in a moment. But the key point is, this is a normal-looking scan. The blood vessel is cut side on. So you're seeing a normal blood vessel lined by Claudin-5. This p-tau, this deposition, is not visible on this scan. This is a normal brain scan, a brain image. This is Kenny's brain. You can see that the normal red is scattered all over the place and replaced by the p-tau, okay? And that's it in high power. And there's the Claudin-5. So this got me interested in the idea with Matt that it's not so much this protein that's interesting, because it does appear in other neuropathological conditions, but it's what it's replacing, it's what it's removing. It's what's happening to this Claudin-5 that's interesting. And we published this then in the Journal of Neuropathology and Experimental Neurology as blood-brain barrier dysfunction as the hallmark, and that's the first time that was mooted as a possible underlying mechanism. So again, going back to our normal scan, instead of a normal scan, all we have are symptoms. I've come up with these two acronyms: vertigo, anxiety, confusion, headache, loss of consciousness, amnesia, vomiting. These are the short-term or Vaclav symptoms. And then PADI are panic attacks, anxiety, depression, dementia, young onset cognitive impairment. So all we're dealing with so far are symptoms, which is very disquieting for most of us in the clinical realm. Why is this important? Because obviously sports concussion is a big issue, and it's bigger in Ireland than in most places. So if you include walking, Ireland has the biggest participation in activity in the world. This is a study done through the Health Promotion Unit between 1994 and 2003. And if you exclude walking, Ireland is in the top 3 countries in terms of participatory sport. And we know the figures. Just in GAA alone, you've got 400,000 players, 180,000 rugby players, 450,000 soccer players, and who knows how many in horse riding at amateur level. And then, of course, there's adventure cycling, rock climbing, etc. So we've got a massive, every weekend we've got, thousands and thousands of young people going out to play these contact sports. So we got this group together. That's just some of the people at the Trinity Research Interest Group. And this is where we do our work. We're the largest teaching hospital in Ireland, and we have a whole team now dedicated both clinically and in research terms. And most of the work in the research is done in the Clinical Research Centre. So our research program then consists of a sort of a 5-hour testing module where we do full history, neurological examination, imaging, cognitive testing, blood and genetic tests, and eye function tests. The whole thing takes about 5 hours. So what are we doing, and what are the results? So our hypothesis is that all forms of traumatic brain injury, either transient or permanent damage to the blood-brain barrier, and that the leakage of fluid and organic material that results from blood-brain barrier dysfunction can be detected by imaging, physiological and cognitive testing, and serological markers. So that's the hypothesis we're working on. To talk a little bit about this blood-brain barrier, so this is a mock-up of the number of blood vessels in your brain. This is usually surprising to most people. So there's no brain cell in the body, and remember, there's literally billions of brain cells, but no brain cell is more than 10 microns from a blood vessel. That's about 0.004 inches. So a human red cell is about 5 microns, a human hair is about 75 microns. So blood is one of the major constituents of the brain apart from neurons. So think about that moving at 20 to 25 kilometers per hour and then stopping, and imagine what happens. Now, what's unique about the brain's vascular structure is that there's a mesh called the blood-brain barrier, which doesn't occur in any other organ. So in the liver, this mesh is wide. Lots of molecules flow in and out of between the liver and the blood. And the liver does lots of filtering of poisons and various toxins. Every time you take a tablet, it pretty much goes to the liver and gets checked over by the liver for toxins, and they get removed or not. But in the brain is very picky about what it lets through. And so both water and certainly all large molecules are highly regulated. And it's one of the problems actually in treating brain diseases, particularly brain cancer is that it's very hard to get chemotherapy into the brain because the brain barrier doesn't like drugs going over it. And so there are these things called tight junctions. You can see it there. And that's the only way that these molecules can get through. And this little stitching pattern here, this is the Claudin 5, this is this protein I was talking about. So the Claudin 5 is stopping things leaking over across the barrier. So what happens is when you get a traumatic brain injury, that blood-brain barrier breaks down. Everything starts leaking out and the brain barrier is broken. And what you see then is over days, this is day 2 from that injury, the white stuff is blood, but all the dark stuff is water. It's just fluid. Now the brain is bursting out of the skull, okay? There's no room for the brain to move, so they have to remove the skull in order for the brain to swell up. And you can see blood is only a minor part of this. The majority of this is water. So our theory is that this water accumulation is happening even at minor amounts in all forms of injury, and this is where it gets controversial in the question of subconcussive blows. So what our study there consisted of, we took 18 boys from an elite rugby school in South Dublin. 11 boys completed the entire study, which was they had to have a pre-season scan and a whole range of tests, and then a post-season scan and a whole range of tests. And then we took 7 under-20 college players, and we imaged them pre-season, and then immediately or 2 hours after they had played a contact game. Really important point, none of these had a concussion. When they had these tests, they were not complaining of a concussion in the recent past, and none of the 7 players imaged after the matches had a concussion during the match. I'm talking about a clinical syndrome now. I'm not saying they didn't take blows, they did, but they weren't complaining of any symptoms. And this is just an example of what we've been doing. So what we do to assess the integrity of this blood-brain barrier is we give them a tracer. It's a special tracing agent called gadolinium, and it's used widely in the clinic. However, what we do slightly differently is we hang around, we wait about 25 minutes after the injection to rescan them. And that's not done normally. And what we're seeing is that there's a leak of this fluid, suggesting that the blood-brain barrier is not working properly. And there you see, in this scan, you'll see that I'll go between the two. So the leakage is the red. So this is the scan at the beginning of the tracer injection. And there's a little bit of tracer excess, which is about 0.02, which is normal. But by 20 minutes later, you can see the red is coming in and the amount of the tracer coming out is increased. So just to show you those, so this is the scan when it's just done. This is the tracing leak. And we can see this is pre and post, the leakage. This is actually one that was done after the match. The leakage looks worse in this, but in fact, the numbers who had blood-brain barrier dysfunction in the immediate after match was not particularly different from the immediate after season. And so we have to try and explain that. So we're working with a guy called Alan Friedman who developed this technology. He's an Israeli neurologist who works in North America. He's been looking at American college football players, and he recently published results showing 40% of American college players showing this characteristic blood-brain barrier leakage. If we count the boys on the elite schools team plus the college players, our figures are 33%. So there's a lot of convergence between these two figures, and we've recently submitted for publication jointly work that Alan's done. We've submitted the 2 manuscripts together to the same journal because they're so similar in their findings. What else did we find? So we've done a series of unique biomarkers as well that we find elevated after the season. So this is a BDNF, brain-derived growth factor, MCP1, and then interleukins produced in monocytes, which is an indication of inflammation. So these are very unique, and again, I credit Matt with doing this work. These are very unique markers that are not normally seen. So when you hear about work around serological or biomarkers, nobody has published these yet. And when we did those ordinary serological markers, we didn't find anything. So we think this is going to be another unique finding. Genetics, I think, is going to be hugely important. So one of the reasons that you might explain why only 40% or only 33% had a problem is that maybe there's some particular unique factor which makes somebody more susceptible. So for instance, one of the boys who had abnormalities on his scan has a genotype called ApoE4 genotype. He's homozygous for this genotype. Now this genotype is a particular genetic factor which has been shown to increase the risk of developing Alzheimer's disease in young age. So this boy actually has this, plus he has this blood-brain barrier dysfunction. Now, we don't know what that means. We don't know that means he's definitely going to develop problems, but it's just another set of questions that are being thrown up. What are we doing? Ongoing future studies. So we're collaborating with the MMA group. So what we figure is, we have all this interesting data from groups of players who had no documented concussions. So now we want to go into a group of players that are definitely going to have concussions, and we know that somewhere like a third of MMA bouts end in a technical knockout. We're definitely talking about concussions in these groups. So we've developed links with the MMA group, and we're going to be doing studies on them because we want to have people who had definitely had concussion and see are the results different. And one of the most interesting ones is this year of retirement study. So the idea is to take all elite players, professional and amateur, in their year of retirement, to invite them in for a cardiovascular and brain health study, follow them every 5 years, and then 20, 30 years down the line, invite them to submit their brains for brain bank donation. So that's going to be an amazing repository of information that's not been equaled, as far as I know, anywhere else. The other brain banks don't have this cumulative clinical data that we're going to get. So the last one is to look at study of symptomatic retired players, which I'm not going to talk about today. Finally, I'm just going to talk a little bit about some other work that I'm doing, and Niamh Lynch is on this group with me. So we're doing a systematic review of the management of concussion, and we have developed a guideline group through the National Quality Assurance Criteria and the National Clinical Effectiveness Committee. It's going to take about 2 years to come up with a group of consensus guidelines. This is our development group. So we've neurology, pediatric neurology, emergency room. We've got engineers, surgeons, rehabilitation specialists. All the experts you would want on this group are there, and we're going to come up with a set of criteria that are evidence-based about the management of the concussion. How are we funded? It costs about €3,000 for each scan, each subject. So it's very expensive, and that includes genetic screening. With that and the guideline development process, we're trying to raise about €2 million over the next 3 years for all these studies. And obviously, for the ongoing year of retirement study, we're going to have a stream of funding. That's a challenge. Can I just say this is the last one. I'm going to put on my American accent again for this. This is about helmets, okay? Because people always talk about helmets. And this is Andrew Ling, who's a lieutenant in the Marines, and he's a helmet expert. If you look historically, what really hurts our soldiers from blasts, it's artillery shells, mortar shells, Ling said. The combat helmet was designed particularly for mitigation of fragments. It does have some ballistic protection. You could shoot the thing at point blank with a 9mm pistol and you wouldn't penetrate it. That's pretty doggone good. I'm surprised New York City policemen aren't wearing the goddamn thing. But I wouldn't play football in the thing. It ain't that good. Thank you.
At the beginning, you mentioned that you're a parent.
Yeah.
And pretty much parents hat now at the moment. The worrying thing for me is the not to put tickets every day. So he came home during the week saying, Dad, my vision isn't great today. We playing today, yeah, I was playing rugby, and then I play football later on. What do you say to parents whose you can't, the symptoms of a regular 14-year-old, apathy, lethargy, mood swings, that's normal for a 14-year-old, 15-year-old. So as a parent, what can you advise from your research and as a fellow parent, how do you manage the kids when they come home in the evening with these vague symptoms?
Well, the first thing is my son has had 2 concussions. When he had the full spectrum of dizziness, feeling tired, drowsy. I remember the coach dropping him home one day and being delighted to find out that he was dropping him home to a consultant neurologist's house. He didn't have to worry about where he was going after that. No, look, I think I have a lot of fear about it. I don't know what to say to you. My son is now 14, so the mini rugby thing. I think they do a good job at managing that, and I think the rate of hits and stuff is low. But I'm getting into a phase now where I'm getting worried. And if he said to me one day, look, I don't think I'm going to do that rugby thing, I might give a sigh of relief because I'm worried. A piece of advice I would give to anybody who's coaches: don't let them wear scrum caps. At least don't let them wear scrum caps if they think that the scrum cap is helping them with concussion. Because I've talked to coaches and I say, well, what are you doing about mitigation of concussion risk? Oh, well, I made sure they wear their scrum caps, because of course that just changes the child's behaviour, and it's not been shown, of course, to mitigate any of the effects of concussion, and it makes them more likely to feel safer, etc. I mean, in fact, the one thing about NFL is if you wanted to make NFL safer tomorrow, you would get rid of the helmets. I mean, the helmet technology is just going through the roof, and there are companies making millions out of designing new helmets. But the point is, if you want to make it safe, you just stop, because they would immediately protect their heads. It would be a totally different game, obviously. So I think the scrum cap issue is important to get that across. I do think, and this is going to come up in the guideline development group, what I think needs to happen is that the codes need to consider rule changes. See, this is my point. I've said this in public before. I think the codes, all of the codes, including GAA and rugby, are to be congratulated on their recognition of concussion issue. That idea that they recognise it, they pull people off, they rest them, they put them through protocols. I'm fine with that. It's the other bit. It's the prevention piece. It's what rule changes need to happen to make it safer. And unfortunately, certainly at the elite level, it's getting faster and heavier. I mean, I hadn't watched rugby over the summer, and I watched the Leinster game last Friday night versus Edinburgh, and I was wincing my way through it. And I realised that when you're watching rugby through the season, you sort of get inured to it. It's just, that's what rugby is. But when you haven't watched it in 3 or 4 months, and you watch a game, and you go, oh my God, the speed and the hits. So the question is, what needs to be done within the game to prevent? And I don't know that conversation, we've won that conversation yet, because of course at the very elite level, the reason the game is as popular as it is because it's becoming faster and more powerful. So I'm dancing around your answer. Like, I haven't stopped my son playing rugby, but what I did do, and I'm not recommending this to everybody, I got his genotype. I made sure he wasn't ApoE4. I got that done. You can get that done, by the way, 23andMe. It's a commercial company. They ask for a saliva sample. It costs €109. You send it off to London, and you can get your ApoE genotype done. So I just wanted to make sure he's definitely not heterozygous for ApoE4. But apart from that, I haven't stopped him. But rambling answer, sorry.
I had a question about you had 18 students at the start of the year and 11 finished it. Did 7 drop out because they felt that they'd had a concussion and didn't want to find out what was wrong, or is that just...
Yeah, that's a good question. There's in scientific and clinical research, there's this notion, what's called intention to treat. You have to analyse your data based on the fact that, it could be that those 7 had more problems than we knew. But, we had a good connection with the group, and it seemed like it was more logistical issues. It was the end. Like, remember, these guys had just finished school, and some of them were attending college, and they'd left the country, and, there were various things like that. So it was more logistical. But you're right, it's certainly not to be sniffed at.
And are schools' rugby teams happy that you're doing this research, or are they terrified by what you might find?
No. This stuff is being driven by the parents. I mean, we went and talked to the team, talked to the parents, and they were absolutely fully on board. I mean, they absolutely want this. If you look at the one, again, important rule that is different in the Southern Hemisphere to what we do here, was driven by the mothers, and it was in New Zealand, of course, the teams are made by weight. So all the teams are weight, they're not age-based. And that was mothers. That's not a World Rugby. World Rugby didn't export that. They didn't want to do that. But in New Zealand, the mother said, I'm not letting my little fella play your little fella the same age who's 11. And that difference was driven by the parents. So, no, this stuff is being driven by parents. They obviously want to know the answer.
Colin, you talked about cognitive reserve being protective. Is this a kind of a fixed thing within an individual, or is there anything that can be done to kind of improve cognitive reserve, and particularly starting at an early age if we are talking about young people playing head injury sports?
Yeah, well, I'm not going to take credit for that point. That was Peter's point. My view of cognitive reserve is maybe slightly different. Cognitive reserve, all that means is that, if somebody has an emerging cognitive problem, if they have, if they've done, if they're using their brain and they're actively mentally active, you're less likely to see that as quickly. So to me, it's more an obfuscation. I don't think improving cognitive reserve is necessarily going to protect. I think that's a controversial area in dementia. My feeling is that it's not stopping the person getting dementia, it's just delaying the diagnosis. But obviously mental activity, when we do have people with emerging cognitive impairment, we do talk about keeping as well as possible from a symptomatic point of view. But I don't know what we can do in childhood for that.
Yeah,
Sorry, just speaking to the point of cognitive reserve, Sabina Brennan, Trinity Brain Health. It's the area I work in terms of dementia risk reduction, but it also improves prognosis in brain injury and also in people with multiple sclerosis. And what cognitive reserve means is that through certain lifestyle activities, you can build up these reserves that allow you to be more resilient to injuries and to disease. It doesn't stop the underlying disease or injury, but you have more reserves, be it that your brain is more effective and more efficient and may even have more neurons and connections, so it allows you to resist the injury. And that applies in stroke as well. Two people can sustain a stroke of the same magnitude. One can have severe impairment and the one less so. But it's lifestyle factors, being physically active, being mentally stimulated, socially engaged, and also managing things like blood pressure, type 2 diabetes, weight, smoking, alcohol, all things around a healthy life, healthy heart. But really, challenge, change and learning, keeping your brain stimulated can help really build those reserves. And I think it's something we should be alerting our children to from the same way as we do in terms of getting them to brush their teeth. It's an investment in the future that might allow you to be more resilient.
Yeah, thank you for that. And we could maybe talk afterwards a little. I think we need to acknowledge that it's still a controversial area, exactly what the cognitive reserve means. I don't think it's proven that what it certainly is proven is that people who have cognitive reserve do better. That's absolutely clear, right? But in terms of the level of, say, neuropathology in the brain, it may be the same. Now, what you're saying is that it is different, that the cognitive reserve, you know, and the lifestyle and the mental activity actually reduces the burden of the pathology. Now, I'm saying, well, I think some people say that, and I think it's a reasonable hypothesis, and I'd potentially believe that to be true, to be honest. But I think it's yet to be proven. And but it's certainly, if you have cognitive reserve, your symptom load is going to be less, and your ability to manage with your symptoms is going to be better. So there's no question that there's nothing to be lost by doing that. What its exact neuropathological effect is still a controversial issue. But anyway.
I just wanted to ask about, you know, the scans that you put up with the blood-brain barrier, and what control group, you know. Yeah, so we had 7. Sorry, I didn't have all of the data. We had 7 young people who were athletic, so that was a kind of challenge. So we got tennis players, we got rowers. The idea was to have people who didn't have a history of contact sport. It's actually really difficult because, you know, one guy that we thought had a long history of playing tennis. He was playing for the school team and everything. And then we found out in 2013 he'd been knocked out when he played a GAA game, so we had to exclude him. It's actually really hard to find people who have no history of playing contact sport. So we had a control group of 7 players, of athletes who were healthy but didn't have a history of contact play. And there was a significant difference between those. Yeah, so the differences were between controls and athletes, but also between the athletes pre and post season.
More down here? Yeah.
So the child on the scan that you showed that had the increased blood barrier?
Yeah.
And then he showed up with the genetic marker. Is that child still playing, or would you be recommending that child not to play? Or
so I was kind of half hoping someone would ask that, but I actually don't have the right answer. So we talked a lot about this case. We talked a lot about whether we should be saying to that child, you shouldn't play anymore. I mean, the difficulty we have with this data is, on the genetic side, that's slightly different. There is certainly issues about the risk of young onset dementia with the ApoE genotyping. But with this data, we just don't know whether these things are transient, what they actually mean, whether they lead to permanent changes or not. And you might as a parent make a decision to say, I'd like to know this information. But from a research ethics point of view, we made sure to say that we didn't know what the results were going to mean, and that we decided not to expose that family to those results. Now, you know, I'm sure there's a big conversation about the ethics of any research project, but because we don't know what these actually mean, whether they're transient or whether they indicate permanent, but we have this boy in mind all the time. If anything we find as we go forward makes us think that these findings are more permanent than transient, we're going to reveal that. But it's a very difficult problem.
Yeah, I just wanted to add a comment on that. Certainly, my reading of the literature on this is that your ApoE genotype doesn't necessarily increase your risk of pure CTE, but it does definitely increase your risk of developing amyloid plaques in the brain, which are the pathological hallmark of Alzheimer's. And so I think it's probably a cumulative effect rather than a pure, that it increases your risk of CT per se. And kind of getting back to that whole cognitive reserve and at what level one displays symptoms, it seems likely, I think, that for the same level of classic CTE pathology, if you add in a degree of Alzheimer's pathology on top of that, plus poor cognitive reserve, you're obviously going to develop symptoms of your condition at an earlier stage and presumably have more severe problem.
That genetic marker, how common is that in the normal population?
About 14% of the population have this what's called homozygous for one particular isomer called ApoE4. Okay. So it's not that many. And only one person in our group had it. He was homozygous.
So that's rare.
Yeah.
Colin, sorry, did I understand you in saying that the blood-brain barrier dysfunction was evident in all of the controlled athletes that you tested, notwithstanding the fact that they had no symptoms, they had no traumatic injury during the course of playing? Am I correct in saying?
So none of the players who, at the time of the second scan, had a concussion. Okay, they'd all played. None of the young players had a concussion during the season, and none of the players, the 7 college players, actually had a concussion before they got the scan. Right, so there were no formal diagnosis of concussion in anyone. What we found was that 33% of the total group, the 2 groups, had this blood-brain barrier dysfunction, which mirrors the sort of 40% seen in the American football players that Alan Friedman looked at. So yeah, so your question is, so it's not concussion that's causing it. Is it subconcussive blows that's causing it? Just a whole season of contact play. And if it is, why don't they all have a little bit of it? And this is where the difficulty with interpreting the results at an individual level mean, and that's why we do research. And that's why that stuff throws up more questions than it answers. One possible explanation is that there's a vulnerable group. 1/3 of players are vulnerable to this. Okay, and we don't know what the factors are which make them vulnerable. We talked about genes, we talked about cognitive reserve, we talked about all these things, and they're all fascinating things, and they throw up. And that's why there's many careers of research to be done in this, and we're not jumping to any conclusions with this work. We're just saying, I suppose the most interesting question is, it brings up the question of, and I think Peter mentioned it there. So you've got these definite CTE cases that never had a concussion diagnosed during their play, right? And then our stuff and Alan's stuff is showing that we're seeing high rates of dysfunction of blood-brain barrier without concussion being correlating with it. So the clinical syndrome of concussion, the thing you're all here, we're going to be told about how to diagnose it, how to recover from it, what protocol to go on, that might not be the big issue. The big issue might be these multiple small attacks. In fact, my hypothesis is, and the one I want to test is, that concussion is protective. Having symptoms is protective because you're brought off the field, you're put on rest. What about the guy who gets the same velocity of bang, right, doesn't get a concussion? At least doesn't complain of concussion. So there's 2 possibilities. Either he actually does not get concussed, has no symptoms. Kenny Newsom was routinely described before he went out on the pitch, going up to a concrete wall in Lansdowne, banging his head off the wall, before he went on the pitch. Right? So there are people who are getting these blows, the same velocity of blow, impact on the brain substance, and they don't have symptoms, and they're not complaining of them. Right? I think they are the people that we're worried about. So concussion itself may be the protective element. Like one issue that's come up a couple of times is why do women appear to have more concussions? And there may be several explanations for that. But one very reasonable explanation is they're much more likely to say, actually, you know, I don't feel right. They're much more likely to do that than boys. I just know that. And there are a couple of factors, including the fact that women have more migraine in general, and you know. But that's a very important point. So I think that we're going to try and look at that hypothesis, that actually concussion, and this will come up by looking at retired players more, and we're going to try and develop this hypothesis that if you get concussion and you come off and you're complaining of symptoms, you're much more likely to be well. Kevin Doyle, I've no doubt Kevin Doyle's going to be on panels adjudicating football and, you know, talking about football teams, and he's going to be fine because he's made a decision to come off. He's made a difficult decision, I'm sure, but I made a definite decision to come off. Whereas, what about all the guys who are just not complaining? And they're going to continue to play for another 5 or 10 years. Sorry, I don't know if you want to moderate.
Wait, one last one there, Kate.
This might come up again later on. But obviously, as technology advances, and a lot of the players now at higher levels are wearing GPS tracking devices, and we get more of an idea of velocity and weight and trauma. Have we looked at, or is anyone looking at the amount of biomechanical trauma that are occurring on those players as to whether they're symptomatic, asymptomatic, and can we quantify in any way the velocity required to get, you know, changes on an MRI scan, for example, even though they may not be symptomatic?
Yeah, so we are working with Stanford University in developing a technology now which is around a mouth guard that has microchip accelerometers in it. They've been looked at in various sports. The problem is that head injury, the biomechanics of head injury or kinematics, this whole area of kinematics is very complicated. There are ballistic forces, there are rotational forces, there are lateral forces. So it's actually very hard to get, but it looks like this mouthguard technology might be the best one, and we're hoping to get these, we'll probably have them in the next couple of months. They cost about $500 each, but they have all this accelerometry technology built into the mouthguard, and we'll be using that in our next set of tests. So I think it's a really interesting question, you know, two people getting the same velocity of speed, one who gets symptoms, one who doesn't, what are the factors there? And, you know, whether that then subsequently leads to this blood-brain barrier dysfunction, regardless of symptoms. So.
Yeah, okay.
More.
Of the groups that you did, the 7, was there what positions were they playing? Was there any difference between the people that took part in the scrum or the backs?
The numbers are too small to draw any judgments on that. So there wasn't a pattern particularly about the position of the field. I think it's going to turn out to be important when we get the numbers bigger, but the numbers were too small for us to make those kind of judgments.
Okay. What do you think is going to be the backs or the forwards?
Well, Kieran Sims, who's one of the guys who's associated with the Craig Group in Trinity, is a biomechanical engineer, and he's published work showing that the one thing that's absolutely clear is the person getting the most impact is the tackler. So the tackler is getting the head injuries in rugby. So that might be true right across the board, in which case it might not actually differentiate between backs and forwards. You know what I mean?
Yeah. Okay, if anybody has any more questions, obviously we'll deal with them a little bit later on. I think you're sticking around for a while.
Yeah, I'll be here, yeah.
Okay.
Okay, thanks a lot.